Well, it's a real pleasure to be here today. You know, as we heard, we've all been socially distancing and trying to live this crazy life of a pandemic that hopefully is coming to an end soon. I think that there are all really positive signs that that the numbers are going down, that the treatments are more effective. So I think that there really is a positive spirit that we're heading in the right direction. We established Cori 14 years ago to really try and cure this dreaded disease, cancer. I think everyone in the room knows someone that is dealing with cancer in some way. And cancer is just one of these awful diseases that creeps in the middle of the night. It's unexpected, and it changes people's lives. I think that what's important for everyone to know is that most times cancer is preventable, and not only is it preventable, but if we all pay attention to screening and we're diagnosed at an early stage, it's mostly curable. So with that in mind, I really want to introduce to you today one of the world experts in the field of breast cancer. This is Breast Cancer Awareness Month. October is always a special month for everyone. But Dr. Dennis Holmes, to go through his CV would probably be for hours. He has served in so many leadership roles, both locally. He's been a professor at USC. He's written extensively in the field of breast cancer. He actually ran the biggest symposium in breast cancer in 2019 in the whole country, the American Society of Breast Surgeons. This organization includes all the leaders in breast cancer, not only in the country but throughout the world, where some of the latest treatments are discussed. And Dr. Holmes ran that meeting. He's also known to think out of the box. He wants to change the way people think about breast cancer, to give, to offer new treatments. And so, I think we really are in for a treat to have really one of the world leaders who has made such a big difference in saving so many people's lives with breast cancer, Dr. Dennis Holmes.
After that introduction, I'm afraid to say anything. I'm afraid I'm going to disappoint everyone here. But thank you for having me come. It's great to see people in person again. I actually started this morning at about 4 a.m. Moderating a meeting that was based in Atlanta, a virtual meeting. When I agreed to moderate the meeting about a year ago, I assumed I would be in Atlanta moderating the meeting that started at 7 a.m. But instead, I was in LA moderating a meeting that started at 7 a.m. in Atlanta, which meant that I had to be up at 4 o'clock, ready to roll. So I'm a little tired. But I hope that still I can deliver what I think is an important message about breast cancer opportunities as well as innovations. The topic that I chose was cryoablation of breast cancer in the context of patient-centered care. I'm going to talk about both of those things, but just so that you know the content of the talk, the focus, it'll be on the idea of cryoablation, which is a technique of treating breast cancer using a freezing technique. Cryo means basically cold or icy. Ablation or ablatum means to remove, and so it's a strategy for treating breast cancer without surgery, instead using a needle that can freeze a tumor until it's dead, and use that as a replacement for the traditional surgical approach. It is one of the non-operative ways that we can manage breast cancer. I had a chance to write about this approach in a recently published book chapter. The chapter was called Role of Non-Surgical Management of Breast Cancer, Endocrine Therapy, which is hormonal therapy, and tumor ablation, in which I focused on cryoablation since it's the most developed form of non-invasive treatment of breast cancer. Now, although it might be new to you or to some people in the room, the concept of using freezing to treat breast cancers is one that was developed many years ago. In fact, the first case of it was about in 1850 when they used really cold ice water to treat a bleeding tumor, to prevent it from bleeding and also reduce pain. But most of the focus of cryoablation in modern times has been the use of it as a strategy to treat other types of cancers. And in fact, it's been included in the treatment guidelines for a number of cancers, such as those listed here: liver, kidney, pancreas, skin, colon, and prostate cancer. It was a little late to the party when it came to treating breast cancer, because for many years, we treated breast cancer, and pretty much still do, with treatments that are not very burdensome. They are burdensome, but they're not as radical as removing the whole breast. We have techniques that can remove just a part of the breast. So because the modern treatment of breast cancer is considered to be relatively low burden, non-burdensome, looking at non-surgical ways of managing breast cancers has not been a priority for many people. But early on, there was an interest in using cryoablation as a way to treat benign tumors, to eliminate the need to remove those tumors. And those tumors are called fibroadenomas. And in fact, the first use, widespread use, was in treatment of benign tumors. But when I learned of it, I was a trainee about 20 years ago. I did a fellowship in 2002 to become a breast surgeon. And I recognized cryoablation as a tool for treating benign tumors. It was immediately apparent to me that this should one day be a treatment for breast cancers, that we should have a different way of treating breast cancers than the way we've been treating them in the last 100 years, which is to do, extensive surgery. That if you have the right tumor and the right technology, you should be able to treat it in this way. So I set about the task of learning how to do it, because I wanted to one day be able to participate in trials and lead trials that focused on developing this as a breast cancer treatment. And the appeal of it is that it's very similar to the experience that some of you might have had when you've had a breast biopsy before. It's a procedure that's generally performed in the office. It's performed under local anesthetic. It involves simply insertion of a few needles. It takes 1 hour, and the person can drive herself in, drive herself home, and it's done. It's a great idea if it can work. We had to prove that it can work. It's also particularly timely because, as you know, in the past year, the healthcare system has been so disruptive. Patients haven't been able to get screened. If they've been screened and diagnosed, they've been in delays in treatment because operating rooms have not been available, surgeons have not been available. There's been a real contraction of available services. So there was a great need in that setting to treat breast cancers in ways that did not overutilize the healthcare system. So cryoablation sort of fulfills that, and I wrote about various ways that breast cancer treatment can be advanced with the use of cryoablation, especially in the setting of a pandemic. But the core part of this message, and what I'm going to spend a few minutes on, is the concept of patient-centered care, which is providing care that is respectful of and responsive to individual patient preferences, their needs, their values, and ensuring that their values guide treatment decisions. And the reason why this is important is that we often talk about patient-centered care. I mean, it's a term that's been around for a while, and we throw it around so liberally. But the reality is that in most situations, the healthcare system isn't as respectful of the needs of patients. And so what we end up doing is saying, we will respect your care as long as your care is consistent with our values. As long as the options, as long as you're willing to do what we have to offer, as long as you're willing to do what we want to do. And I think the best gift that I learned or had or developed in early in my career was that I listened to patients and I responded to what they told me. And because of that, it was clear to me that what we were doing then, what we're doing now, is just not enough. And we need to have better options, more options for patients, because not everyone is willing to do what we want them to do, or what we have wanted them to do. So the concept of patient-centered care really places the patient at the center of the matrix. It has to reconcile, her actual tumor anatomy, her actual tumor biology. It also has to look at the treatment options that are available. But ultimately, we need to look at the risk tolerance. What risk is she willing to take? What treatment is she willing to accept for the treatment of her breast cancer? And ultimately, weighing all of those things, you can kind of dial up the treatment or intensify the treatment or de-escalate the treatment based upon the size of the problem, the options you have, and of course, based upon what the patient is willing to do. And this is particularly relevant to me because I see patients weekly from around the country, especially now that we do telehealth all the time, around the country and around the globe that are seeking something better than they have in their home community. When they go to surgeons and they say, well, I have a mastectomy to offer you, I have a lumpectomy to offer you, those are my options, take it or leave it. And for many people, that's not acceptable. They're looking for something better. And that's where patient-centered care has to be reconsidered. So I have set about the task this past month, although I've been thinking about this for years, of preparing a TED Talk. A TED Talk is like an inspirational talk because there's this message that I felt I needed to communicate, that I'm hearing communicated to me, and I needed to sort of organize it in a way that would be a 10-minute talk that people want to listen to. And so there are 3 principles in the TED Talk, and it's not available yet. It's in the works. But this is part of the process of developing the idea, is that I kind of have 3 audiences for this TED Talk. One is the importance to patients, which is to tell them that their values matter, and to encourage them to find doctors that respect their values, that will work with them where they are, to sort of guide them along a path that respects their values. It's a message to doctors that it's important to respect patients' values, even if it does not meet the standard of care, because many of us are so afraid that we're going to do something wrong if we don't offer you the right treatment, that we simply say, well, we can't help you, so go find someone else who can. We never are willing to compromise. And the last part is a message to the research community and the medical device community that we need to have more options. If you have more options, then you can find something that fits more patients, and people can find something that meets their values. And so that's really the perspective that I bring to the research that I've done in the topic that I'm going to present to you later in this talk. But this is what, just to emphasize, drive the point home, what we traditionally face. It's a cartoon, and there's a guy who has some fancy new advancement, wheels, round wheels, and there's someone with square wheels trying to move a barrel of stones, and he's off from the round wheels, and the guy with the square wheels says, well, no thanks, we're busy, we're too busy. We're too busy doing what we're doing that we're not open to looking for something that might be better. And that is really the challenge that cryoablation faces today, that it is an innovation that is effective, although it's not suitable for all problems, but it's up against a challenge, and it's fine, we can take challenges, but it's where we are, and it's a culture of medicine that we just need to continue to overcome. Because we've done it before. For example, if you could have open heart surgery like the lady here on my left, or have the same problem treated with a catheter inserted through your groin with the same outcome, which would you choose? Why choose an extensive surgery when you can have a minimal procedure done that accomplishes the same thing? What about a cholecystectomy? Would you like the large incision on your abdomen, or 3 small holes that accomplish the same thing with quicker recovery and fewer side effects? It's the same thought about cryoablation. For people that undergo the procedure, as I said before, it's office-based, it's done in less than an hour in most cases, it's done with local anesthetic. Patients drive themselves in and home. They resume normal, non-strenuous activity the very next day. Their pain control is accomplished with Tylenol and a sports bra. They need nothing more than that. And so what we try to accomplish is, what we try to accomplish with cryoablation is essentially the same thing that a lumpectomy aims to do, which is to treat a tumor completely with a surrounding margin. And in this picture, you see the kind of the tumor shown there in red, and there is the kill zone, if you will, the part that is killed, shown in gray, and then there's the ice ball, the rest of the ice ball, that's shown in blue around it. So you basically freeze a larger area to kill a smaller area that contains a tumor. And we freeze the tumor at its very center down to minus 185 Celsius, and we accomplish, this is an ultrasound of an actual cryoablation procedure. This is an ice ball. The blue thing is the kill zone, and the star-like thing in the center is a tumor. And what we're aiming to do is to kill the tumor with a surrounding rim of tissue that is also killed that measures basically between 5 millimeters and 10 millimeters. Essentially what we try to do when we perform a lumpectomy. And as with lumpectomy, patients would go on to receive radiotherapy if that's appropriate, or medication if that's appropriate. The advancement of cryoablation was really made available. I told you, it was done 150 years ago, but advancements really came about because of some technological advancements in having streamlined systems that can allow you to perform cryoablation using a handheld handpiece that you can use in your office, using liquid nitrogen. And the needle is a hollow needle. The liquid nitrogen flows through the needle, and it freezes the tissue around a segment of the needle. The whole needle doesn't freeze, but there's a part of the needle that's not insulated where it gets really, really, really cold, and that is a part that we center in the tumor in order to ablate or destroy the tumor. We freeze it through 2 cycles, so we typically do an 8 to 10 minute freeze, and then we allow it to thaw 10 minutes, and then we freeze it again for another 10 minutes because we know from studies that a double freeze is more effective than a single freeze. And ultimately, through various mechanisms, the tumor is destroyed. I've listed the primary mechanisms shown here. There's an osmotic injury, meaning that there's some fluid shifts that causes the cells to basically rupture open. There's mechanical injury when icicles form inside the cell. It destroys the cellular organelles, the structures within the cell, and the cell wall. There's a vascular injury. The freezing causes the blood vessels feeding the tumor to clot. And when the blood vessels clot, there's no blood or oxygen being exchanged, no nutrients, the cells die. There's a cold injury called apoptosis, which is that at a certain temperature, there's a trigger that causes some cells to die. And so in the right zone, at the right temperature, the apoptosis induces cell death for these cells. And then the most intriguing part, but the least understood part, is that there is an immunogenic injury, which is that there are clear indications that when you freeze a tumor and allow it to die in place, when your inflammatory cells move in to clear away the debris, there is an opportunity for your immune system to recognize the cancer cells as foreign and then react to those cells wherever else they may appear in the body. And just this past week, I reviewed a paper. Now, most of these studies are done in mice, so you need to wait till we review these things in humans. But I reviewed a paper in mice in which they repeated a previously performed experiment which showed the same result, that if you put a tumor here and you put a tumor here and you ablate this tumor responds. So how does it respond? It's responded because the immune system responded to this one, and then the immune cells went over to the other one and induced a response, meaning that it causes a shrink. And so the phenomenon happens, but we're still trying to harness it to understand it and also how to amplify it so that it works reliably and effectively. I have a little video here which just shows you some of the things that I just described. So this is just a cartoon of what happens. So I talked about the osmotic injury where the cells swell because fluid distends the cells, causing them to rupture. There was a quick image where you saw icicles formation within the cell, which caused the cell to be injured. And there's also icicles formation between the cells, which has the effect of pulling water out of the cells. The cells shrink, and then during the thaw phase, which is very important, the water flows back into the cell, causing the damaged cells to rupture open. That's how that happens. I talked about the vascular injury. The blood vessels clot. When the blood vessels clot, vital nutrients can't get to the cells die. And then, of course, there's the intracellular freezing, which is, as I said, the icicles form and disrupt the cells. Now, this is an actual video of a procedure, someone undergoing cryoablation. Hopefully, it's not too uncomfortable for those who are watching, but at this point, I'm injecting local anesthetic. So you see a needle coming here from the left. I injected local anesthetic within the breast, within the skin, and now I'm making a small skin nick, 3 millimeters. That's as big as the incision, that's as large as the incision needs to be. I insert a longer needle and put more local anesthetic in, closer to the tumor. And so you see the needle coming in. I'm putting the anesthetic between the tumor and the skin. The tumor is this dark area right here. Actually, I have a pointer. The tumor is a dark area. The needle is that white line. And I'm injecting local anesthetic, lidocaine, between the skin and the tumor. This is all the steps that were taken before we start the ablation process. We just anesthetizing the area. This is the actual cryoprobe, and inserted through the skin and through the tumor. Someone's turning their head away. As you see on the ultrasound image, this is the cryoprobe, this is the tumor, and the idea is just kind of like to insert the cryoprobe completely through the tumor so that it's centered within the front and back and edges of the tumor, and also that the tumor is centered in the right segment of the probe, the part that freezes completely. You see the tumor here, again, the cryoprobe is here entering, and this is actually the cryoprobe that's now through the tumor. The tumor is in this position here, and this is the other direction, the tumor here, so the cryoprobe there in the center. And one of the things we have to do when performing the procedure is we want to freeze the tumor, but we don't want to freeze the skin. So in order to prevent that, one strategy is to inject saline under the skin to push the skin away, to allow room for the ice ball to form without freezing the skin. And let's see what's happening here. Oh, so now the cryoablation is started. And what happens is that this dark area forms, you probably remember the dark area from the photograph I showed you earlier, but it forms an oval dark zone. The ice doesn't conduct the ultrasound signal very well, so instead of it being something you can see completely through, you can really only see the edges. Once the cryoablation is done, actually, we're not done yet. So here's the injection of the saline. You probably saw the tumor come down. That's because I injected saline between the tumor and the skin, and the tumor was pushed down, or the ice ball was pushed down, to provide protection of the skin. That's the ice ball again, and that's the needle coming from the other direction. This catheter here is actually the catheter that contains saline that I'm injecting into the skin. The cryoablation continues. As I said, there are 2 freezes. There's a thaw in between, and then once the treatment is done, we simply wait a couple of minutes for the needle to warm. It warms so that it can be withdrawn from the breast, and then we simply put a bandage on the incision, and the patient goes home. That's the entire procedure, and it typically takes about 4 to 5 minutes to complete. Now, the evidence for the effectiveness has been evaluated in a number of trials, some of which have been completed, some of which are ongoing. One of the first trials that I joined was the ICOSOG trial. This was started in 2009, in which we treated 100 patients. All of the patients had cryoablation, and they underwent surgery after cryoablation to see how well the cryoablation worked. The study found that for tumors under 1 centimeter, the ablation was 100% effective. For tumors under 2 centimeters, it was 92% effective. And we learned something about the technique, which tumors were better, which tumors were not so good for this, what approach was more effective, and we adapted it so that it could be applied to future trials. I then followed that trial with a trial that I started called the FROST trial, which is freezing alone instead of removal of small breast tumors. And it was an approach whereby we would perform cryoablation of the tumor, but not follow it with surgery. We would leave the tumor in place. And this is an ongoing trial. We're actually in follow-up mode now. So we're not enrolling any more patients. We're just following the outcome of those that were treated. But it was women with basically tumors 2 centimeters or smaller, estrogen-sensitive tumors, and tumors that were very well seen by imaging because we needed to have a very clear target. So you had something like this, where you had an obvious tumor, or something, maybe there's a little white tumor at the edge of the image there on the MRI. Maybe you can see it. But the idea is that you need to have a clear target because we're relying upon the ultrasound features of the tumor to help us understand how big the tumor is and how much area we have to ablate in order to completely treat the tumor. This trial was sort of divided into women that were older who just got cryoablation and medication, and there's also a younger group that got cryoablation plus radiation, because for younger women, radiation is more important. But the idea was that everyone was going to have cryoablation and no surgery, but 6 months after cryoablation, the plan was to, or the practice was to perform a biopsy of the tumor site to confirm that the tumor is dead. That's how the trial was designed. This is one of the participants in the trial. Can you tell which breast had cryoablation? Which breast had breast cancer? Well, if you look at the picture with the arrow, that probably helps. But you can't tell because there's no visible effect on the breast that you can see, except for a small 3 mm skin injury, which is in this breast. The tumor is in the right breast, but you can't tell from the outward appearance of her breast. This was her mammogram performed, let me change this pointer. This is her mammogram performed before cryoablation. Let's see if I can show you laser. Her tumor is here, that white spot right there. And this is the same area 3 years later, no tumor visible. The body has absorbed the area that was treated. This is her MRI. This is a tumor on MRI before treatment. This is the side of the tumor 3 years later. So all it took was the needle inserted into the breast. We killed the tumor. The body absorbed it. This trial is ongoing. There's a trial that recently reported some interim results, and there's a longer trial that's been, that has 6 years follow-up, and all of them show essentially the same thing, that for the right tumors, so basically tumors under 2 centimeters, when they're targeted with cryoablation, so you have very clearly seen tumors targeted with cryoablation, the recurrence rate between 3 and 6 years, if you average these trials, is about 1 to 2%. That we can achieve the same thing with cryoablation that we can achieve with surgery for these stage 1 tumors, which is what this technology is best designed to treat. So in the last few minutes, I'm going to talk about sort of where we're heading, because I think, although we are following the outcome of those trials, I think the data are clear that it works for that problem. The question is, can it work for this problem? The problem that I have here is ductal carcinoma in situ, which is stage 0 breast cancer that generally presents as calcifications, that does not generally present as a mass that you can easily see. It's not as severe. It's stage 0 breast cancer. It doesn't have the ability to spread. It's a thing that may lead to invasive breast cancer, but it doesn't have the ability to spread. No one dies from DCS. But it's hard to evaluate and hard to measure because it doesn't form a mass in most cases. It forms these tiny calcifications that you can only see in many instances on the mammogram. Now, DCIS, which is what we call it, is basically breast cancer that is confined to the inner lining of the milk ducts. It has not yet invaded the tissue outside of the milk ducts. It's stage 0 breast cancer. And as I said a moment ago, it's usually detected because we find these tiny white calcifications on your mammograms, which is why it's important to perform mammograms, because it's the best test for finding breast cancer at its earliest stage, which is stage 0 breast cancer. But although this is a problem that is not as severe a health risk as invasive cancer, it's a challenging target for cryoablation because it doesn't form a clear mass that you can see by ultrasound. So we had to develop some solutions for that. But just to give you a little bit more context, this is what DCS looks like under the microscope. It's a really, really large duct that's been dilated, that's been magnified. This is the actual milk duct here. And the calcium deposit is this. That's what the calcium deposit looks like under the microscope. But we can't see that on ultrasound. We can really only reliably see it by mammography. So a little bit of background about DCS. So DCS represents about 15%, 1 out of 7 breast cancers diagnosed today. That's about 50,000 women a year. Most cases of DCS simply remain DCS the entire lifetime of the woman. We think maybe between 25 and 50 will progress to invasive cancer, but the rest will stay DCS. It would never become a worse problem. The issue is that it's hard to tell which ones will progress and which ones won't progress. So because of that, we treat them all. And we treat them all the same way that we treat an invasive breast cancer, which on one hand might be good, but in most cases is overtreatment because, again, most of them will not progress. That's what we know. In the US, currently about 50% of women with a diagnosis of DCS have a lumpectomy and radiotherapy. About 25% of them have a mastectomy. And then others may have lesser procedures, but most people have the same treatment that we would treat a stage 1 or stage 2 or stage 3 breast cancer. Yet DCS is stage 0, and for most people, it would never be a problem to their overall health. So we need a better solution. So we basically, I've been working on developing cryoablation as a treatment option for women with DCES, with the primary goal of using it as a substitute for surgery, and as a secondary goal of using it as a way to induce an immune response that will discourage the formation of invasive breast cancer or other cancers in that breast. That's a separate research topic and a separate presentation. I'll focus on the first one. So the question is, how do you make this thing that is not visible by ultrasound so you can cryoablate it? And so this is what we usually start with, which is something like that, calcifications. Occasionally we have DCES that has formed a mass that we can see by ultrasound, like you see over there, but most times we don't have that. So the workaround was to utilize ultrasound visible markers, clips, what we call them, that could be put into the breast at the site of the DCES so that we have now a clear target, a clear target, a clear target, a clear target. There are different shapes and sizes, different devices. I prefer to use the one that's called a secure mark, which is a bigger target. But basically, once a woman has been evaluated, we've assessed the size of the DCES, we've judged that it's reasonable, that it's small enough to permit cryoablation, we can insert the needle at this target, and, well, I'll step back. We insert this target at the site of DCES, and then we use ultrasound to guide us to that target so that we can ablate that target, the DCES at that site, plus a rim of tissue around it. This approach of using cryoablation as a way of treating DCIS has been formalized and developed as a clinical trial. The trial is called DCIS Cryoablation Trial. It launched just this month. We treated our first 2 patients 2 weeks ago. The trial is a trial of women aged 18 and older with DCIS measuring 2 centimeters or less by mammography and MRI, if MRI was performed. Everyone will have undergone a needle biopsy so we can diagnose their DCIS. We take the pathology slides, we review them, we make sure that that diagnosis was correct, was correctly interpreted, and then we perform cryoablation. So this is basically the key steps. It starts with a consultation with me where they're enrolled in the trial, their pathology is reviewed. If they need a placement of that marker, then they undergo marker placement. They then come back to the office for cryoablation. We perform the cryoablation. It generally takes about 45 minutes to an hour. Then they go on to have radiation if it's appropriate, medication if it's appropriate. And then 6 months later, they have a biopsy done of the site to confirm that there's no living DCIS present. After that, they go on to continue yearly mammograms, and again, they take medication and radiation as indicated by their condition and based on their consultation with their other specialists. I am thankful to Cori and other organizations for help funding this trial. The primary funder was doTERRA. It actually was quite an inspirational thing. I had a patient who had DCIS, who received cryoablation off protocol because I didn't have a clinical trial at the time, and she wanted this to become a treatment option available to other women. I said, well, I'm happy to help. I'm happy to do that, but I need funding. So I applied for a grant that I did not get. I'm really upset about that still, to do this study. And it was not funded. We'll come back to that someday. But this patient and her Facebook group said, we're going to raise money to do this trial. And so I told them what it would, it's kind of bare cost to do the trial. We need the equipment. That's the main thing. The equipment to do cryoablation is that's what is kind of hard to acquire and to use because it's specialized equipment. So they raised the money to buy the equipment. And then I went to the Cori Foundation. I said, well, we have money for the equipment, but there are administrative costs, like to run the trial through the IRB. They charge me to do that. So would you fund the IRB costs for this trial? And they said, yes, we would. And so they did. And so they gave us a grant to do that. And then I decided that I would volunteer my time and my staff time so we could do offer the treatments. And then the company that makes the device, I said, well, you guys need to give us a break on the cost. And they did. So we're able to enroll more patients. So it basically is a community event to make this happen. And the last part, doTERRA is a company that makes like essential oils and things like that. It was actually a matching grant campaign where they match the monies raised by the women dollar for dollar. So that's how we got the study funded. But again, thank you all and thank Cori and so forth for making it possible to do this trial that otherwise would just be an idea and not realized. So in conclusion, although I've sold cryoablation as a really promising treatment option for the future, you should recognize that it's not the right solution for all problems. But then again, nothing else we do is the right solution for all problems. It's a matter of figuring out which solution best matches the tumor biology, the tumor extent, and the patient's risk tolerance. And some may want to have a mastectomy to treat their DCS. Some may want to avoid surgery at all costs to treat the DCS. There needs to be a way, there needs to be an approach or compromise so that we can adapt the solutions to the problems as well as to the patient's values about how they should be managed. If you want to learn more about the trial, you can visit this website, cryoablation.com, or if you want to send me an email about it to find out more about the trial, info@cryoablation.com, or there's my office number there. I will conclude the presentation now, and I don't know how long it's taken me to get to this point, but if I have time to take questions, I'm happy to do so. Thank you.
Okay, thanks, Dr. Holmes. Very informative. Are you considering the clinical trials for human subjects as opposed to animals and mice? Okay, that's one question.
Yes, yes.
Okay, good. Good. Yes, the answer is yes. Now, next question. In the cryoablation treatment itself, are there any side effects from the freezing for 10 minutes and then going off and then freezing again for 10 minutes? Are there any side effects that these women should expect from that?
Very good question. So the first question is that all the clinical trials are trials in humans. I referenced trials that were done in mice. But we have translated, where possible, that to the use of to treatments in humans. So the trial is a trial performed in women who have been diagnosed with breast cancer. And cryoablation is a treatment that has side effects like everything we do, potentially, but they're fairly mild. So they're basically similar to the side effects you have when you have a needle biopsy performed. There's bruising, there's swelling. For cryoablation, there is more bruising because of how the blood vessels are clotted by the freezing technique, but that actually is beneficial here because we need that clot to form to help kill the tumor. And there's also potentially more swelling because we have to inject saline in the breast to protect the skin. But as I said, I asked them to use Tylenol and wear a sports bra, and over a 2-week period, the breast essentially returned to normal pretty much. The last part is, since we freeze an area that's larger than the original tumor, there is a larger lump that forms in the breast at the side of the tumor. So you have to be aware of that. They have to be they have to be comfortable with that idea. And we give them the ability to be even more comfortable with the idea when they realize after the biopsy that it's just a healing wound, not living cancer or growing cancer.
Okay, so thanks so much, Doctor. Welcome. So can this cryoablation be also used in men with real breast cancer?
It can be used in men. The limiting factor is that we try to avoid ablation of the skin, and most male tumors are very close to the skin. But as long as there's a little bit of separation between the tumor and the skin, we can squeeze in enough saline to prevent the skin from freezing, and therefore it can be an option for them. Now, they're not included in this trial, but I'm just responding to your question. Yes, it is possible to do so.
Good. Yes. My last thing, and I'm going to sit down here. Somebody else may have a question. So, we know that there are pronouns associated with breast cancer in general, the HER2 negative. Is there one for the men, or would you be interested in starting one for the men? Pronoun, HER2 negative, right? So him, something, or something. I know. It's just a question. Hey, I'm a men's advocate, so that's a legitimate question.
I would support it, but my plate is full.
Okay.
Really full.
Thank you, Dr.
Thank you.
Thank you.
Thank you.
And the patients that you have treated, has any of them relapsed or anything else mass back for the ones that you have been watching and monitoring?
Yeah, so with any treatment that we do, there's a potential for recurrence, and that's one reason why we traditionally will combine lumpectomy with radiation and medication, because we know lumpectomy alone isn't enough. Adding radiation to it isn't enough to prevent a recurrence, and adding medication tries to get us to the point of having no recurrences, but that also might not be enough. So one of the sort of the things that I try to get people to start with, at least, is that don't expect cryoablation to do what it can't do. It also is a targeted treatment. It can kill what you see. The problem is, what don't you see, and what can we do to control that risk? So in the trial that I presented a slide where I showed you several trials that are looking at cryoablation, and for these favorable groups of people with small tumors under 2 centimeters, there was this basically a 2% recurrence rate at 3 to 6 years. And that number might go up, but that mirrors also what we see with lumpectomy, that you have about a 2% recurrence rate at about 5 years for typical stage 1 breast cancer. I think one of the challenges, and it's a challenge that we have to work with, is that sometimes people that don't want to have surgery also don't want to have radiation, and they don't want to have medication. And so in the context of patient-centered care, as long as they understand that that comes with some risks, we have to respect their decision. It just needs to be a clear-eyed decision. I don't want them to have like magical thinking like the cryoablation replaces all those other things. It does not. But we have to respect patients' ability and decision-making about their self-care, and that's one of them that we do, as long as we disclose clearly what the consequences of that decision might be. Thank you.
I know you're talking about breasts. However, does cryoablation work with prostate?
Yes, it does. And in fact, one of the resentments that many women express is it seems to be so much more developed and widely accepted for prostate than for breasts. Why is that? Why do we have billing codes for prostate and more established use of it for prostate when we don't yet, or we're just at the beginning of having billing codes for breast and no established trials? And so, yes, it has been used for prostate. It is currently an option for prostate, a non-surgical option for prostate. I can't get into the politics of that, but we're getting there for breast cancer. But it's used in prostate and other organs as well. Okay. Thank you all very much. It's been a pleasure joining you today.
Thank you, Dr. Holmes, for that wonderful presentation. I'm sure that everyone has had an opportunity to learn some information or hear some things that you were already familiar with and gather information. I'm sure there will be contact information, Dr. Holmes, provided later. Should anybody have questions for you? Okay, perfect. All righty, so before we move on with the program, this is always the fun part. We have some raffle prizes in the back. Trying to make sure so I'm gonna grab one. All righty, so my winning ticket for this first prize is 348093. Again, the number is, this is your blue ticket, 348093 is the winner present. Is that you? Okay, congratulations. And Ms. Terrell's gonna come around with something. Thank you, thank you. So we will return with a few more prizes. So we will move on with our program. We now have a genetics presentation where we have a facilitator, Ms. Aarin Ables Williams, and just allow me to introduce her. Aarin Ables Williams is a certified clinic genetic counselor at Kaiser Permanente, Southern California. Her role at Kaiser focuses on general genetic counseling, which includes the provision of care for prenatal cancer, cardiac, pediatric, and adult indications. She is an alum of Howard University and a graduate of the Stanford University School of Medicine, master's program in human genetics and genetic counseling. Aarin attended the genetic counseling field, motivated to increase healthcare literacy among unrepresented groups, and is passionate about mending the healthcare gap for underserved communities. She uses her training to play a role in the stories of families as they navigate moments in their lives where genetics education and support have impact. In addition to her work as a clinician, Aarin is a member of the National Society of Genetic Counselors, Justice, Equity, Diversity, and Inclusion Committee and serves on the UCLA Genetic Counseling Master's Program Advisory Board. She has presented diversity education for genetics colleagues, facilitated learning for aspiring healthcare providers, given seminars to community members, and has provided genetics training for the California Department of Public Health's Sickle Cell Counselor Training Program. She also volunteers with Camp Crescent Moon, a summer camp dedicated to serving children with sickle cell disease, an excellent program, I might add, as the education program coordinator and camp counselor. Aarin enjoys staying active, reading, and experiencing the world with her husband, Dr. Jamal Williams, and their young daughter, Mariah. And now I'd like to bring up Ms. Aarin Ables Williams.
All right, there. Okay, so good afternoon, everyone. My name is Aarin Ables Williams. I'm a genetic counselor at Kaiser Permanente in Southern California. I work here in the LA area. I grew up in this area off of 64th and Dinker. So I'm really happy to see so many community members here. I feel really empowered to see you all getting more information about how to be more proactive about your health. And so I'm going to be discussing with you a little bit about the genetics of breast cancer and why your family history is so important. So we'll start off with a little bit about myself. I had a lovely introduction here, but I'm a genetic counselor at Kaiser, as was mentioned, but I'm a woman and a black woman first, so this is really important to me that we all find a way to build community around the idea of being proactive when it comes to our health care and managing risk reduction and prevention of breast cancer. So this is Breast Cancer Awareness Month, but this is also Hereditary Cancer Awareness Week. So the transition between Ovarian Cancer Awareness Month and Breast Cancer Awareness Month, this one little week right here, is nationally recognized for hereditary cancer risk. Okay, so let's jump into the presentation and kind of talk a little bit about cancer and genes. Before I start, how many of you, by a show of hands, have been touched by breast cancer? Either because you know someone, you have a personal history, or you have a family history, right? And so when we think about cancer in general, unfortunately, living life, we all have the chance to develop cancer in our lifetimes. And when cancer happens, we can kind of divide the way we think about it from a clinical standpoint into two different features, the sporadic cancers and the hereditary cancers. So the sporadic cancers here, let's see, on your right, okay? These are occurring because of differences that our body is kind of picking up or acquiring over time, right? If we live life long enough, we can find that a tumor may form because of differences that are occurring at the cellular level inside of our body. And these can happen in any of our organs, right? And so over time, we might collect mutation after mutation, change after change that will then allow a tumor to form, which is basically just a big clump of cells that have lost the right instructions and they're growing out of control. So that rapid growth is what causes a tumor. Okay. With hereditary cancers, if we kind of take a step back and think about what hereditary means, these are differences that we are born with, passed on to us from our mother and our fathers. So just like eye color and hair color run in families, our genetic information helps make us who we are, and that information is shared between relatives in a family, right? So with hereditary cancers, we think that people are born with an increased chance to develop certain cancers because the instructions that made them who they are were passed on to them working differently, essentially broken copies of these genes. Okay? And so we might then see that in all of the cells of a person's body, that first mutation is already there because that's the way that they were born. which means that it may take less time for a cancer to form because the body already has one of those instructions knocked out. Okay? We have 2 copies of each of our body's instructions in the cells that make us who we are, the one that comes from mom, the one that comes from dad. So if we find that people are born with a difference or a mutation in one of these genes, that difference can then increase the chance that they'll develop cancer over time. Certainly not a guarantee, but a much higher likelihood depending on the kind of genetic change that we find. Okay? And so if we think about breast cancer specifically, we know that about 85% of breast cancer is happening because of factors we can't really pinpoint, right? Either because there are triggers in the environment, in our lifestyle, or a combination of genetic components that might be causing a tumor to form. Okay? But in these small sections here, we see that there are genes that we're born with that are not working properly that can then lead to an increased chance for developing cancer. So the biggest pink triangle here, that piece of the pie, is the BRCA gene. Show of hands for anyone who's heard of the BRCA or the BRCA genes before. Okay. We're going to talk about them in one moment. And then those smaller pieces of the pie are a couple of other hereditary cancer genetic susceptibilities that we're studying. Okay? And so with hereditary breast cancer, the genes that people are most familiar with are BRCA1 and BRCA2, which literally stand for breast cancer gene 1 and breast cancer gene 2. These are the first 2 genes that were studied in connection to cancer running in the family of the breast and other organs. But we know a lot more about breast cancer genes at this point beyond BRCA1 and 2. Okay? So again, everyone has copies of these genes. We all have 2 copies of them. Okay? But people who are born with an error or a mutation within these genes will have a higher likelihood of developing certain cancers. And so this chart here, which is kind of cut off toward the end, shows that the likelihood of breast cancer for women who carry genetic changes is a lot higher than the general population risk. So just living life as women, we have about a 12% chance to develop breast cancer, 1 in 8. And when people are born with mutations in BRCA1 or BRCA2, they have a higher likelihood of developing not just breast cancer, but prostate cancer in men, ovarian cancer in women, and pancreatic cancers in both men and women. Okay. Another important thing to think, though, about our genes is that just as our information was passed on from our mother and our father, we have the potential to pass those changes on to the next generation, too. And so this here is a breakdown of some of the cancer genes that we study, right? And again, it's the mutation within these genes that increases the risk for cancer. So this kind of covers the whole gamut of the body parts that we really focus on when we're thinking about hereditary risk. So if you take a look at that big blue line that says up to 99%, that's for a very rare genetic condition that increases the risk of colorectal cancers. If they're not treated and managed, nearly everybody who carries that genetic change may develop a colon cancer. But that's for Colon Cancer Awareness Month, okay? And so when we think about these hereditary cancer risks, about 10% of cancers are due to inherited gene mutations, okay? So that means that 85 to 90%, we can't really quantify from a genetic test, okay? We know that about 1 in 300 people are affected with hereditary breast cancer mutations, specifically BRCA1 and BRCA2. That's about 25 million people, okay? The issue, though, is that when people think about these differences, they're not always thinking about all of the communities that they'll impact, right? The likelihood of being born with an increased risk for hereditary cancer is higher for breast cancer in people who are Ashkenazi Jewish. Their chance to develop breast cancer because of a genetic change that they were born with is 1 in 40. But for everyone else, that risk is 1 in 300, right? If you think about your church family or even your family at a family reunion, you know 300 people. If you really, really think about it, count them all your Facebook friends, 1 in 300 people are born with a change that increases their chance for breast cancer, right? But 90% of people don't know it, okay? So when kind of thinking about all of the information that's available to us in our community about breast cancer or BRCA mutations, there are a couple of studies that have evaluated what people think about BRCA1 and 2 and then the reality of the situation. And so for people who carry BRCA gene mutations, we know that the risk for breast cancer is higher. But if you have a family history of cancer and you do a genetic test and we don't find anything, that doesn't mean that you shouldn't still be screened for cancer, okay? Because these mutations are indicators of risk, but we're always learning more about how our genetic information increases the chance for certain diseases. So your family history is important, whether or not a genetic test gives us the answer to the question about where cancer is coming from, okay? And then the other thing to keep in mind is that some people think that because women are the ones with breast tissue that's very different from men, and that women are the ones who have ovaries, that we're the only ones who can pass these genetic changes on to our children, and that this would just be a change that a mother could pass on to a daughter. But these genetic changes are found in both men and women, and they can be passed on from a mother and or father to son and or daughter, okay? And so when do we think about hereditary cancer in the genetic setting? When we get a referral from a doctor who's seeing a patient and they notice certain things about this patient and their family, we think that genetic testing could be appropriate. Okay. The first is a personal history of more than one type of cancer. And so if a woman has had breast cancer and colon cancer, or if she's had breast and ovarian cancer, or thyroid and breast cancer, then we wonder, is lightning just striking more than once in this woman? Is she the one that just has the buzzard luck? Or is there something that is triggering these cancers to form because of the way that she was born, her genetic code, right? If we see cancer at a really young age, and we're thinking something younger than 50, so if we get a breast cancer and someone is in their 30s or their 40s, we're wondering, what about this woman cued this earlier onset cancer than what we would typically see? If there are multiple people in a family with cancer, if there are similar or associated cancers within one side of the family tree, or in some cases, like with prostate cancers, if it's a cancer that's very aggressive or metastasizes and spreads, then we think maybe genetic testing could be appropriate in this family. And so genetic counselors really wear the hat of providing information about the benefit of testing, evaluating the family tree, advocating for our patients to make sure that if we find something that they get the kinds of management and treatment options that they need, and then providing a support to them as we kind of navigate this process. Okay, so knowing about these things can really help form combined decisions between a patient and her care provider about what's going to work best for her and her family. And why should this testing be done? And so my role is to really focus on the patient in front of me, but it's often that when we're finding something, the information is so much bigger than that patient, right? Because when we think about our genetic information, that's what ties us to our family. And if we find that there's a genetic change in someone who's had cancer, her close relatives, like her children, her siblings, her parents, depending on her age, also should be provided with this information so that the family as a whole can really see who in the family needs to get screened better, who should be offered better management or surgical options from their care team based on this info, okay? And that's what we call cascade testing. So we can target medical treatments, we can detect other cancers, and we can really figure out who else is at risk to develop cancer when a genetic test is done for a patient. And that brings us to the question of who in the family should have the testing done, okay? One of the common misconceptions that we get in the genetics clinic is that the person who has had cancer doesn't need to be tested because they've already had cancer, right? But their relatives are wondering, what does this mean for me? Now, in reality, the person with the diagnosis of cancer is really the one who can give us the best assessment of hereditary risk in a family, because they're the person in the family that makes the whole history look suspicious, right? And We get half of our information from mom, half from dad. We share half of that information with our siblings. So it's possible that we can do a genetic test and someone who has no cancer history themselves and get a completely normal result, but we were never really answering the question about what's going on in the family. It's better to start with the affected individual if we can. Okay. Not everyone wants to pursue genetic testing, though. So if we run into a dynamic in a family where there's a really strong pattern for cancer, but either the people who've been diagnosed with cancer have passed away, or the people who've been diagnosed with cancer just don't want to do genetic testing. And we can test those unaffected relatives, but we have to test them with the caveat that, as I said before, we might not really get at the answer that we're looking toward, and we call those results true negatives if we happen to find a mutation in someone else, and then we can tell our patient, we know what's going on in your family, and we just didn't find it in you. You weren't born with that change. And so I would be remiss if I gave a presentation about genetic testing but didn't talk about some of the challenges that people might have in getting the testing done. Okay. Now, there are national guidelines that we're using at Kaiser and that major medical centers are using everywhere when they're thinking about hereditary risk. Okay. Most insurance companies will cover the cost of genetic counseling and genetic testing for people who meet those national guidelines. Genetic counselors can also help determine if you qualify for testing and genetic services. We can also write authorization letters and help with repeals if it's a test that you really want to pursue and it doesn't get coordinated for you because of a denial. But an important thing to keep in mind is this law called GINA that I bolded here. The Genetic Information Non-Discrimination Act stops health insurance companies and employers from discriminating against an individual's genetic information. So if you do a genetic test, and say, for example, your mother was diagnosed with breast cancer. She did a genetic test. We found a mutation that she was born with that explains the diagnosis, and now you want this information for yourself. You want to be proactive. You want to see how you can get screened, but you've never been diagnosed with cancer. If we do this genetic test for you, and we find that you were also born with that change, that counts as a pre-existing health condition. Okay? Now, insurance companies and employers cannot discriminate against you because of that information. But that doesn't apply to life insurance, it doesn't apply to disability insurance, or long-term care. Okay? So sometimes when people are wanting this information, especially if the cancer risk in their family is really prevalent or the mutation really increases the chance for cancer, it's important to make sure that those sorts of things are in order before you do your genetic test, because it can be a challenge to get those insurances in place if you do it the other way around. Okay? And so I just want to close with a couple of important points. So cancer is a disease that can affect everyone, but it does not affect everyone equally. Okay? There are plenty of disparities in healthcare when it comes to cancer and Black women specifically. Okay? Black women are more likely to die from breast cancer than women who are non-Hispanic white. We're more likely to be diagnosed with breast cancer at a more advanced stage. But we're underutilizing these tests. We're less likely to be offered genetic testing for hereditary cancer, but studies show that when we're offered testing, we are just as interested and just as motivated. And so we have to be our own advocates, okay? We're understudied. When we look at the genetic data that we have and the research that's done on breast cancer, 81% of this research for hereditary cancer has been done on women who are of European descent. So that leaves a big chunk of the US just not knowing whether or not this is something that they need to be concerned about for their families, okay? And a recent study showed that over 50% of white women who were eligible for gene testing had an awareness of BRCA genes, but only 11.4% of Black women did. And so in thinking about some additional barriers to genetic testing, it could be a lack of diversity and competency among your care providers. If they're not culturally aware, if they're not culturally competent, then they might not be providing you with care in a way that you can relay it to your family members, that you can receive it and understand it and really do something about it. And if patients leave their doctor's appointments without a good understanding of their options and what they mean, then what benefit did we really do? And then we talked a little bit about the financial aspect. Genetic counseling and genetic testing should be covered at no cost for people who meet that criteria, but oftentimes the concern about the cost of testing might be a barrier in families as well. And we all know that there have been plenty of previous abuses of the medical system that would really impact whether someone would want to hand their DNA off to have a test done, right? And so how can we break this cycle? I think that in an ideal world, we'd see no more missed opportunities for women when it comes to early detection and prevention of breast cancer, okay? In order to do that, we need to advocate for ourselves. We need to be educated and empowered. And we need to be ready to put ourselves into action on our own behalf. Okay? The collaboration with your care team is important, but collaboration with your family is important too. You know, if you're interested in genetic testing, get a network going. Speak to your family members to see whether cancer is something that might be on the side of the family that you weren't thinking about. You know, oftentimes women might say, well, my grandmother had cancer, but it was my father's mother, not my mother's mother. But your grandmother is your grandmother, and that DNA got passed on to dad and then got passed on to you. And we can miss a whole chunk of really important information if we're not thinking about the fact that your genetic information doesn't discriminate. It doesn't care whether this was your mother or your father who passed this gene on to you. But if we know what we're looking for, we can do something about it. So if you're interested in genetic testing, do some homework on your family tree. The important questions are who, when, and where. Who had cancer, and how are they related to you? My family, I have lots of cousins, but if we think about how closely we're related to one another, they could be, our grandmothers were sisters, or it's my grandmother's aunt, I call her my auntie, but she's really my second cousin once removed, right? So think about the DNA that you're sharing with these relatives. How are you related to the people who've had cancer? How old were they when they were diagnosed? And where did their cancer start? Because if we know that someone passed away from cancer, we want to know where the tumor started in their body that spread, that caused their demise. It's important to know not just where the cancer was when they passed, but where it started, okay? Again, be your own advocate. If talking about these things, this young diagnosis, multiple people with a history of cancer on one side of the family sounds like your family tree, discuss the option of testing with your doctor. And you can find genetics providers at findageneticcounselor.com that might be able to provide you with some more information. Okay, so I'll stop there. I just want to thank Miss Livingston, I don't know where she is, for allowing me to come and speak to you all today. You've done such an amazing job getting all of these people together who want to be informed and people who want to inform. So thank you for everything that you're doing. And then thank you to the Inglewood Southside Christian Church, too. Thank you for putting this together. Any questions, anyone?
You mentioned a couple times about the criteria, if you meet the criteria.
Yes.
Is that a reasonable set of facts and questions?
Yeah, so I think it is. The national guidelines are put together from major medical centers who are evaluating people who are concerned about hereditary risk. So for breast cancer specifically, if you have a personal history of breast cancer and you were younger than 50, depending on the kind of cancer you have, if it was triple negative breast cancer, if you have a personal history of cancer over 50, but you have 2 other close relatives in the family who are blood relatives to you who've been diagnosed with breast cancer, if you have a relative with ovarian cancer, if you have a male relative who had metastatic prostate cancer, if there's someone in the family who's had pancreatic cancer, those are the kinds of things that will trigger our checklist to say this family should be offered testing. Now, when you see your genetic counselor, they'll draw out the family tree, try to see who in the family is connected to one another, and then take a note of everyone who's been diagnosed with cancer so that we can try to make those connections, because we don't want to miss the opportunity to give families information that's going to be helpful for them, right? But the guidelines are there to help ensure that the yield, the pickup rate of testing is really going to be beneficial, as opposed to just doing a test because someone has had breast cancer, because we know 85% of the breast cancer that we see isn't going to flag on a genetic test because we don't understand the components of it. Okay, so if you go to, on a Google search, NCCN is the name of the certifying criteria board that helps us know who should qualify for breast cancer, hereditary screening, and testing. They also have an assessment for colorectal cancers too. For colon cancer, we're thinking early age of diagnosis, close relatives with things like prostate, a pancreatic, or a liver, a biliary tract cancer, and again, multiple people in the family with the same kind of cancer. Yes, yes.
I noticed here in your bio that you are a genetic counselor at Kaiser.
Yes.
And as a Kaiser member, if I wanted to get a genetic test,
yes,
I could just request that, and would it come under your guidance?
That's an excellent question. Okay. So for any Kaiser members out here, especially if you're getting care in this area, I would love to see you. But the referrals that we receive usually come from your care provider. So if you talk to your primary care physician and you share with them that you're interested in genetic counseling, they should be able to place a referral with either myself or one of my colleagues in the South Bay area. If you get care in West LA, then that's a different group, but we're all kind of under one big umbrella. We'll be able to discuss your family tree with you and then see if you meet the criteria for testing. For the families that don't meet criteria, we usually end up having reassurance to give because there's a reason why that family tree doesn't check those boxes. Either we see cancer, but people are in their 60s or 70s when they're getting it, or we see cancer, but the kinds of cancers that we see aren't the ones that fit that hereditary pattern, right? And so I would love for you to reach out to your doctor to request a referral. And if you get care in South Bay, the genetics department is at the Carson offices on 190th and Figueroa. You can come see me anytime, okay? Any other questions? All right, well, thank you so much, everyone, for your time. Enjoy the rest of the presentation.